We're now on to the next session that is called The Big Conversation. What are the key priorities for CCGs post-authorisation? And I'm really pleased to have three very good speakers to actually give us their view about what the priorities are for their CCG. On my far left, we've got Dr. Stephen Richards, Chief Clinical Officer for Oxfordshire Clinical Commissioning Group. In the middle, we haven't got Dr. Andrew Coward, who is not with us, but we have got a wonderful replacement in the form of Dr. Steve Carrell, who is the Chair of Bassett Law CCG, but also Steve is the co-chair of the NHS Clinical Commissioners Leadership Group. So it's great to have you here, Steve, and for stepping in at the last moment. And then on my closest left is Dr. Helen Tattersfield, who's Chair of Lewisham CCG, and she's not Helen Tattersfield Coward either. So just Helen Tattersfield, but be amazing. So what we're going to do is ask each of the speakers to go across the lectern and just give us up to 8 minutes of their view about what the priorities are for their CCGs, challenges, opportunities, those sorts of things. Run straight through those, and then we'll have an opportunity for about 5 minutes of Q&A if we run to time. So we'll have to keep closely to time, but hopefully there will be an opportunity for a few questions. So without further ado, I'll hand over to Stephen Richards. So Stephen, the floor is yours. Thank you.
Thanks very much, Julia. Just before I get going, I'd like to embarrass our chairman by confirming that her daughter has just informed her she got a first in her degree. Small round of applause for Julie's daughter. Okay. Quite quick fire. First one should also say Vice Chair of Health and Wellbeing. Apologies to social care colleagues, that's a really important bit of what I do. So, picture to start with, self-explanatory I think. Do we really have this concept of assumed liberty, or are we nearer to shades of grey and command and control? I very firmly believe that it's up to us as CCGs, 10 weeks old, to make sure it's the first, that liberty to really drive change that we must pursue. So, as senior clinical commissioners and others here present, what do you think keeps you awake at night? And I'm told you can press your buttons any time. Quality, safety, how do we empower the public, finance, managing demand, the future, and other. You're not allowed other. Be positive. I think that starts now. Whether it's going to come up, I don't know, but we'll see. Doesn't look like that one's going to. Technology is not my greatest strength. Anyway, it doesn't want to move forward either. Wait. Oh, yeah, look at that. What have we got? D, financial balance. In Oxfordshire, as the second or third lowest per head in the country, that would have been my vote. We've also got quality as a major issue there. Empowering the public voice. Surprised that's not a bit higher, but interesting. Thank you for that. So, challenges. I'm going to bash through these. On one side, we've got the challenges, and on the other, we have possible solutions that we're looking at in Oxfordshire CCG. Quality patient-centred care, absolutely right up there. How do we, with less money, deliver better quality? Datix is a system that all our GPs are using to inform us as commissioners of both patient problems, their solutions to how we do things better. Integration, easy word, very difficult to describe in detail. We are working extremely hard and energetically on delivering outcome-based contracts, specifically for areas of mental health, anxiety and depression and psychosis, maternity, and the big one, which is the frail elderly pathway. Towards financial balance, we're doing much, much more with our county council colleagues, looking to have potentially the biggest single properly pooled budget for older people in the country. Underneath each of these are the specific individuals who are working on those. If you want to know more, feel free to contact them. Slightly contentiously, I put primary care commissioning. Going back to the handcuffs, it was my belief from the word go that by not allowing CCGs to directly commission their GP colleagues, we had and still have at least one arm behind our back in a handcuff. And I think with the relative lack of capacity in area teams, I think this is a growth area, but it's definitely a challenge. Few more. Even in lovely Oxfordshire, we have a 12 to 15 year gap between those who live in our most deprived areas and those who live in leafy South Oxfordshire, like me. I hope I live longer. We're giving practices the information they need to see what their practice and their locality really needs to address. To know if we're doing half of what I want, we need interoperability of the patient record. Colleagues, some of whom are here, have been working on an Oxford Care summary for some years now. It's possibly as well developed as anywhere in the country, but we're looking to move one step further, inviting the industry in its widest sense and our commissioning support unit colleagues from Central Southern to work with us to actually crack this nut of the shared patient record becoming a reality. Outcomes gets a second mention, not just because it's in the NHS framework, but actually because we believe this is where we should be focusing our capacities. And there's a bit on our website which just defines and describes that a bit further. Ultimately, our biggest challenge is older people. Growing, growing, growing. We have to keep them healthier, at home for longer, and we have a variety of models we're trying to do to deliver that. So, thank you for listening. Julie hasn't jumped up and down to tell me I've finished, so I have finished, and I'm happy to take questions later. Thank you very much.
Thank you. Thank you, Steve. Okay, so from leafy shires of Oxfordshire into Bassett Law, which isn't one of the core cities outside of London, but Steve keeps trying to make it there. So over to Steve Carrell. Steve, thank you.
Thank you. Steve and I come from different ends of the CCG spectrum. So a huge CCG, less resources possibly for commissioning services. A different issue for us, a small CCG, 112,000 patients in North Nottinghamshire. Very tight running costs, need to work really closely in partnership. So different issues for both of us. The title of this talk was Issues Post-Authorisation. I just wanted to make a quick point that authorisation was a point in time. So we're past that now, and I think we're all learning the realities of clinical commissioning, about what that means for our organisations. It's really good to be focusing on the patient part, the quality part, instead of organisation, instead of site visits, etc. These are really interesting time for CCGs. In terms of priorities, I've listed the 4 Ps, and the first one, and by far the most important, is practices and population. As a GP, I increasingly feel that the responsibility for my patients goes beyond my surgery door. The patient in front of me remains the most important thing, but beyond that, I need to start thinking about pathways. I need to start thinking about how good are the quality of the services I'm referring people to. Do I know a lot about the community services that patient might access when they're out of hospital? It's a different way of thinking. It's a really important part of any CCG role, and I think it's one that, if we do our job properly as CCG leaders, that we'll get into our members. We also need to make sure the patients are involved, but in a genuine way. We all talk about patient engagement, but do we really focus on genuine transparency? Do we really focus on honesty about figures? Do we share as much information as we have? I think we're moving there. We need better information. That's a role for CCGs and CSUs, but I think that's a really important thing that I want to get to, that level of information, so patients know local issues and understand the figures behind them. Second is practices. Practices are hugely important. A CCG is as strong as its member practices. GPs hold a huge amount of information. GPs see patients every day and know what the issues are for their patients in terms of pathways, gaps. I'm always very conscious of my role. I do lots of meetings. I can stand up today and talk to people, it's fine. Stand up in front of your GP members, it's possibly the most difficult meeting you'll do. The absolute transparency that you need, the focus on the right things, the consciousness that you're there, that you're elected by your members, and that the focus has always got to be on patients. Focus on the wrong thing. Tell them it's about quality when it's about money. Tell them it's about money when it's about quality. and you've lost patients and you've lost your practices. The third point at P is primary care. And this does concern me. Stephen touched on the capacity of area teams. This isn't a plea for more money, but we do need to recognise that the NHS budget now, roughly 8% of the NHS budget is spent in primary care. Out of every £2,000 spent by NHS England, £180 gets spent in primary care, and yet a huge amount of consultations, a huge amount of workload is happening. And we need to recognise that as CCG leaders if we're going to get the most out of our practices and if we're going to get the best services for our patients. Simply asking them to do more all the time in a way that isn't meaningful, that doesn't add to quality, that doesn't add to the patient journey, will not lead to successful CCG. And finally, partnership. A lot of my job as CCG chair is spent sorting out partners, so whether it's as vice chair of the Health and Wellbeing Board, whether it's dealing with secondary care, community care, the voluntary sector, CSUs, it's a really important part. And then there's the NHS England part, and we need to get this right. There's a tendency as things become more difficult, I said earlier, for things to become more central in times of tightened financial balance, times of tightened quality control. We need to make sure that CCGs play a strong part in this. NHS England has a role as system convener. I would argue very, very strongly that CCGs have a significant role as system convener as well in holding the system together, particularly with fragmented commissioning. And finally, we need to keep commissioning close to clinicians. We need to keep it really close to communities, but most importantly, keep it close to patients. And that's got to be our focus all the way. Thank you.
Thank you, Steve. Okay, so finally, before we open up to the floor, so from large to small to London. So now hand over to Helen Testfield. Thank you, Helen.
Thank you very much. Listening to my colleagues, I realised that CCG work is very different in different parts of the country. Lewisham is an inner city London borough. We are surrounded by bigger, more famous boroughs, and often the left out member of South London. And one of the things that we as a CCG have learnt in the last few months is that we have to stand up for our population, and that sometimes that means standing against the general remit of what is being said. We're about 300,000 in our population, hugely deprived, young population, multi-ethnic, with all sorts of needs. We have no clear source of work in our borough. Most of our residents go out of the borough, so there's not a lot of income in the borough either. So they've really lots of needs. All the things you would expect, COPD, long-term conditions, frail elderly, sexual health. We have sickle cell disease because of our West Indian population, and lots of specialist things like that, lots of patients with HIV and a huge lot of mental health. So seemingly an absolutely enormous area. So where do you start? What do you do? We were very lucky, I think, to start with, because we have one central hospital which does a large proportion of our work, with whom we have really good relations. And we had expected with our CCG to be building very stronger relationships with them, changing pathways, which we'd already started to do, and as well working very closely with our local council. All coterminous, all working together, really good relationships, great place to start CCG. We were really happy and really quite cocky about it, because we thought this is really going to work. And then midway through last year, the South London Healthcare Trust came into the news, and people will have heard of the special administrator. And the outcome of all of that, after lots of consultations, was that the plan is to significantly downgrade our central hospital. Which then what that means is that's going to change all the plans that we have for pathways. All our neat regulations of joining up with the council is all different. Our patients will be in possibly one of 5 different boroughs and not in the borough that we're working in. It's a whole different environment. At the same time, we had to decide, well, do we stand up against that? Do we take a stand and say, right, we don't agree with this is not good for our population, and we are going to, that is our role. You know, my belief is that CCGs were set up to stand up for the role of your population. And clearly what was happening was taking the resources from what is actually the most deprived borough and passing it back to those boroughs which are actually much less deprived. That doesn't seem ethically right. And so quite a lot of what we've done in the last year is actually political stuff, saying that's not right, we should be doing this differently. And that's taken time away from the real job as well. So at the moment, our main priority is making sure that services actually do still exist for our population, let alone whether they're good or not. Are the patients going to be able to access services? Is there going to be an A&E where they can actually get to, or you know, all those sorts of problems. So we have all of that going on. At the same time, we had a population who, as well as being deprived, were sicker than they should be. And some of that was to do with deprivation, some of it was to do with the quality of healthcare being provided by our GPs and also the hospitals. So we had a real need to raise the standards of general practice to the highest. We have some really excellent practices, but like everywhere else, there are those which are not doing so well for a variety of reasons. And one of the things that we've done to try to improve that is really just about sharing information. It's about showing practices how they compare with other practices. It's about having meetings of like-minded people so that they can share that data. We have a complete unanonymized data so that we can see exactly what's going on. That's down to prescribing budgets, referrals, outcomes on QOF, all of those things. And it's amazing when you sit a few practices around and nobody wants to be the least performing practice. And what has happened, having shared that information in specific areas, is really clear improvements. When we started just as a Pathfinder CCG, we looked at what was the needs and the deprivation going on, and we saw that immunisation in our children was absolutely dreadful. We were about the bottom in London. And so we said, look, this is something that GPs can really do something about, and we can make a change immediately. All we did was, with public health, shared the data to practices, told practices that Lewisham was the worst performing borough in London, showed practices how they fitted in, put in a few pathways, and within 6 months we had improved our coverage by 10%, and we're a shade off herd immunity, which is astounding. We've also seen similar improvements in outcomes for COPD, improvements in diabetes, QOF scores at least. It's a bit early to see outcome improvements, but just by sharing information, sharing the problem, we've seen that sort of improvement in our practices. So I really agree with the previous colleague that practices are really important. The other thing that's really important is our links with social care and the council. As I said at the beginning, we have a really good relationship with our council. We already have a lot of joint commissioning for children and some of the mental health services. And we've been building on that, really sharing the problems. The problem with the TSA has in many ways brought us together because the council in fact have taken the judicial review course, so we're supporting them with that. But more importantly, sitting around saying what are the priorities and how can we work together to deal with them? How can we collectively deal with alcohol? How can we collectively deal with obesity? What does the council need to do? What does health need to do? What do the hospitals need to do? So we've decided joint priorities, which are the obvious ones. You know, let's stop people smoking, let's get people eating and exercising, and let's reduce the alcohol. And then we say, right, how can we do that? We can put sequence into the hospital contracts to make sure they do the smoking cessation at every possible point. We can encourage GP practices with local enhanced services, and we can detail the QP part of QOF so that that supports all of those processes. So we're really trying to make life simple, trying to work with the things that are already there so we get quick improvements in outcome without actually having to make anybody work any harder, but actually make just people work more efficiently. We have a real difficult few months ahead as all of this process works its way through, and the added problem that we have locally is obviously finance. And one of the things that we are understanding is that the allocation of money for CCGs is likely to be changed away from deprivation to age, which for our particular population will have huge, significant implications. So we are trying to make sure that doesn't happen, but planning for it if it does by building these relationships and making our services much more efficient. Thank you very much.
Thank you very much, Helen. So three different perspectives, three slightly different challenges, but actually some similar themes coming through. So we've now got 10 minutes for questions, an opportunity to come back to our speakers. While we're getting mics to questions, can I ask you all to give me a number? So if starting from Stephen's first slide, so you have the Statue of Liberty. So if we give the Statue of Liberty a score of 100 in terms of its where we want to be with the nirvana of assumed liberty, with the handcuffs representing a 0 value, because we don't want to be there in terms of command control. 10 weeks in, early days, I know, but give me a number, Stephen. How do you think it feels? And the same Steve and same Helen.
I think it's still pretty high. I'd say we're in the 80s, 90s and need to keep pushing that up for the liberty side. I think the difficulty is that as we get more tactical and the figures come in saying the money doesn't work, then I think we'll get more tactical, more command and control, more old style. We've got to make the most of the window of opportunity to take the assumed liberty now.
Keep it there. Yes, absolutely. Steve?
80, but the direction seems to be going downwards rather than upwards.
Helen?
I think in Lewisham, I think we'd actually say 50-50 because of the battles that we're having. We've got freedom in some areas, but not in others. But we're pushing to go back the other way.
Okay, brilliant. Right, now an opportunity for you. Any questions? We'll take one over here. I'm going to go over to the lectern so that we don't share a mic, Helen.
Thank you. My name's Mona. I'm a pharmacist from London. Thank you for your presentations. I have a question for Dr. Tattersfield in particular. Just thinking about the situation you've described with the financial flows in Lewisham, what you've described is effectively the inverse care law, and also how the situation at CEL has developed. With the benefits of hindsight, what do you think stronger commissioning could have done to have prevented that development of CEL? What could have created a better outcome?
Well, I think it hasn't happened yet, so strong commissioning still has a chance to make sure that population needs come first and not some sort of equation. I think it's just really important that we are assertive and we do speak for our populations, and that also we do a very good job with the money that we've got so that we're shown to be honourable people running the money.
Question? It's awful. One here at the front. If anybody else wants to ask one, if you can wave and I'll try and see you. No? Whereabouts? Just here. So, oh no, if nobody's got a question, can I ask you one then? Steve, you talked about the relationship with practices being paramount, and I think Stephen did, well, you all did, in different ways. How are you doing that? Because to me it's absolutely fundamental, as you say, to keeping your member practices on board. So what are you doing? You talked about that being the most difficult meeting you do.
Well, the challenge for Stephen and I is significantly different. So we have 12 local practices. We have 2 of the largest practices in the country, and 10 other practices. I know my GPs by name. I can meet them all at once. We know each other's practices really well. We share data. And have done on an open basis for quite a long time. So the challenge for me really is partly recognising at the moment where they are as practices, which is to be honest working flat out, and some practices are struggling nationally to cope with demand. So I think we need to be realistic. We need to recognise that, and the CCG has a role far beyond commissioning in primary care. The ability to bring practices together, which was probably lost in the later years of PCTs compared to PCGs, is a significant thing in terms of improving quality and encouraging open peer review, and really encouraging primary care to be as good and strong as it can be. I'm having relationships with practices in a good way that historically haven't been there for a long time. And it's a really valuable thing about being part of a CCG.
Stephen, your take on it?
Yeah, I have, as Stephen said, a bit diametrically opposite. There are 83 practices that make up Oxfordshire Clinical Commissioning Group. There are 600 GPs, 1/3 to nearly 50% are sessional salaried GPs or sessional GPs. I do not claim to have a relationship yet with all 600. I'm delighted to say I do have 6 GP locality leads who intimately know their practices, more akin to your relationship, Steve. But getting to know them, and you mentioned that it's actually sometimes a bit scary standing up in front of your GPs. It's actually also the most invigorating, because every single one of them sees patients and knows that we can do stuff that is better for everyday working as a GP and better for the patient. So I think it's quite scary, but the most invigorating thing is working with the people who see the patients to actually get us back to what we're here for.
Thank you. And Helen?
Yeah, I mean, I fall in between the two. We have 44 practices and about 150 GPs. We've divided into 4, so we have 4 sub-areas where those practices get together, and each one of those has a rep which comes to the centre, and the clinical directors have links backwards. I think it's really important that we do understand the needs of GPs, and they understand that we understand them, so that when we're asking for improvement of quality, at the same time we're giving them the resources to do that, or saying you don't have to do that anymore. So I think it's about a culture of encouragement and peer review, and that has already made a difference, and I think it will continue to do so, providing that we continue to have some resources to offer people.
Steve?
I just wanted to add, an FT chief exec said to me at conference last week that clinical commissioning was the best thing that's happened to him in his career. The level of engagement is and it's particularly powerful when you close the loop with your local practices. So where we've had issues locally with A&E performance, as many areas have, we've worked together, we've met consultants, we've walked around the department. We had a presentation yesterday from the A&E clinical director and managers about what we've done and the effect it's had, and it's been significant. And that's a really powerful thing that practices recognise as being better for their patients.
Okay, thank you. We have a question in the middle down here. Mike is just coming to you, sir. So if you can say who you are and where you're from.
Hi, I'm Andy Steen, a consultant in acute medicine in Coventry. Continuing on your theme, in none of your 3 talks did you mention the glaring problem that we have in secondary care, which is jammed hospitals all over the UK. And I'd just like to know what your plans are to change the paradigm where we have a situation where GPs work 4 days a week, 5 if you're lucky, and hospital doctors 3 days a week, 4 if you're lucky.
Anybody want to respond?
Okay, I obviously do not have the answer to that, as probably most of the people who read the HSJ will know that Oxfordshire is ashamed that it has the worst delayed transfers of care numbers in the country. So let's get that out there. But what we are doing, and it was on my part of the question around managing demand, is we've seen an 11% increase in non-elective admissions in the last year. I have seen more consultants nearly crippled by this on a day-by-day basis, particularly through January, February and March. So what are we doing? As commissioners, I see those providers, I understand the work they're doing as much as I understand the GP community, and we are jointly working together to try and address that demand, how patients are getting there, why they're getting there, finding some answers. So we are working in a way that we haven't done for at least 5 to 10 years in my personal experience in Oxfordshire. Other places may have been doing it better, but we are working together as clinicians with managers.
Okay, quick question.
It's not just about the NHS. I can tell you that locally this year, 11% of our medical admissions or our adult admissions to hospital are medically inappropriate. I can tell you that 70% of the patients who are in hospital beds, adults, are there because we haven't commissioned properly historically the social and step-down beds for those patients to go into. So it's not just about both of us working harder. We need to recognise that. It is about us effectively commissioning, using secondary care and primary care, a better system for patients.
Helen, any final reflections from you?
I totally agree with that. It is about working together and with social care. And one of the things we're doing in Lewisham is really moving forward the integration programme so that we have one point of access for social and health care. And I think that will really help people not need to come into hospital. And I think we also really need to involve the population to understand that health isn't just about hospitals. And we could do with some support from politicians and media on that, I think.
Thank you.
Thank you. We're up against time, so thank you very much to Steve and Helen for their amazing insights, and I'd like to thank them in a normal way. Thank you.